Okay, thanks a lot for the kind introduction, and it's a real honor to be here, and I'm very aware that this is a talk for patients, so although my slides might still be too complicated, and I'm really sorry and apologize in advance for that. So I will try and also stress, these are my disclosure, I will try and stress throughout the talk the global questions that are behind this meeting. So just to start off with, chronic lymphocytic leukemia is very common. And it occurs mainly in patients over the age of 65, but of course in countries where people are generally younger, we also see CLL very much in younger patients. The main thing I want to say here is that CLL is a cancerous disease of the lymph gland tissue and of the immune system. So many patients will present with infections or with a deregulated immune system and problems of the immune system. And each patient with CLL is different. About 2/3 of patients will never need any treatment, and that is also very important when patients are being diagnosed in places of the world where maybe the physicians are not that familiar with treating CLL. It's important to bear in mind that not all patients need treatment. And recently, especially in developed countries, obviously there's a lot of worry associated with watching and waiting. You're being told you have a leukemia, but actually the doctors are not doing anything about it. So it's a sort of watch and worry kind of problem. New therapies have improved the prognosis of patients with CLL who need treatment, but it still remains a chronic condition. That can only very rarely be cured, even in high-income countries. And the treatment, the curative treatment, is with bone marrow transplantation. So what do I do in Oxfordshire? For many early-stage patients who don't need treatment, it's active surveillance, and we don't even see them. They are being referred back to their general practitioners. We are in the process of setting up a telephone clinic as well, where these people can be seen and followed by full blood counts in the telephone clinic. And these are primarily the stage A patients, so people who have got no major lymphadenopathy, and they have a normal hemoglobin and a normal platelet count, and they don't have any symptoms, no B symptoms. The GPs, they know, and our clinical nurse specialists who run the telephone clinics, they know the alert symptoms, and those are essentially when the hemoglobin drops, the platelet count drops, or when there's a big lymphocyte doubling time. New lymph nodes appearing or symptoms appearing. So this then triggers those patients to be referred back to the face-to-face clinic and to be seen by a doctor. What else do we recommend? I hope you can read this, maybe not. I just read it out quickly. So we do say to GPs that they should treat chest infections or any other type of infection very preemptively with a prolonged course of antibiotics. And this is because we assume that patients with CLL are immune suppressed. We also do give advice around vaccination. So all our patients get the annual flu vaccination. And we tell the GPs not to give the shingles vaccination that is available on the NHS for free for patients over the age of 65, because that is a vaccine that is a live vaccine, similar to the yellow fever vaccine, and so patients with CLL should not receive that vaccine. However, there is an inactive vaccine now available called Shingrix that is available at the moment in the UK only privately, and it's very expensive, and many patients can't afford this. We recommend pneumococcal vaccination, and there's a specific way of doing this vaccination that has been defined by the Department of Health here in the UK, whereby you give Prevnar first, followed by a pneumovax at least 2 months later. So all this information, you don't have to write it down, is available on the website, the Oxford website, and I can point this out to you. We also say that people shouldn't smoke. They should always protect their skin, because patients with CLL have a 20 times increased risk of getting skin cancers. And also, I think we shouldn't forget that if antibiotics don't work and prophylactic antibiotics don't work in patients with recurrent infections, we should give immunoglobulin replacement therapy. So if treatment then is required, what are we going to do? And clearly we want to give the most effective agents really early on that have the least toxicity, and the ultimate aim in future would be to achieve cure. And you can see that many new drugs have been licensed in the past few years for CLL. When I started, not that long ago, and in hematology, I'm a bit old now, but not that old, we only had chlorambucil as a single agent. We didn't have much else. And so since then, we've seen a plethora of new agents emerging. This has also been followed, interestingly, by very much progress in the technologies in the lab, to diagnose the different subtypes of CLL and the prognostic and the predictive factors. So generally speaking, what type of treatments do we have? Well, we have got straightforward chemotherapy, and that's basically, I call it domestos, is essentially something that kind of destroys every single cell in your body, especially the cells that proliferate. And so that explains the side effects that you get, like diarrhea or hair loss and the increased risk of infections. And then increasingly we have cell surface markers, so these are these target proteins that are on the surface of the cell. We have got small molecules that inhibit certain protein signaling pathways, in particular the B cell receptor signaling pathway, and those are drugs like ibrutinib and idelalisib. And then we've also got drugs that inhibit the death machinery. So normally when a cell is in trouble or there's mistakes in the cell, that cell will undergo death and suicide. But that's sometimes not happening in cancer cells anymore. So this the venetoclax induces the normal death mechanisms in the cell. And then most recently, and that's got a lot of attention in the press, of course, is that we also have immunotherapies. And we've had immunotherapies for the last 40 years, and it's called bone marrow transplantation. But more recently, this has now gone into various different types of drugs that can reactivate T cells that fight cancer, and also more recently the CAR T cells. So these are the manipulated T cells that would eat up CLL or other cancer cells. So there's very different mechanisms of various different types of treatment. Small molecules, antibodies, the immune system, reactivation of the immune system, and we still also have the chemotherapy that just kills off everything irrespective. What is available in the UK as first-line treatment? Well, although, and I come on to this later, many studies have now shown that the targeted therapies like ibrutinib and the antibodies are better in frontline therapy. The bottom line is that in the UK, in the NHS, we will still give these 3 different types of chemoimmunotherapy on the basis of whether a patient is fit or maybe a bit more frail and has got comorbidities. So that's the truth of the matter, and the reason for this is essentially that these chemotherapy agents are cheaper and it's given over 6 months, whereas ibrutinib has to be given all the time, is very expensive, and in the frontline setting, a lot of patients would have treatment, and so therefore it's not affordable for the NHS. So for those of you who come from low to middle income countries, you're not alone. We are all struggling with the same issue of affordability. Patients with TP53 disruption, however, have got access to ibrutinib in the UK. That's a very small proportion of people, about 10%, depending on 4 to 12%, depending on what test you're using to detect the TP53 gene abnormality. But this abnormality, we know that patients with this abnormality don't respond to chemotherapy, so the government a few years ago recognized that those patients should have ibrutinib up front. It's usually identified by a simple blood test, so there's nothing fancy about it, and the genetic test is really only in the CLL cells. It's usually not in your germline cells, so it doesn't have any consequences for your family members when we're testing for this, with very rare exceptions. However, with patients with small lymphocytic lymphoma, so where the CLL cells are not circulating in the peripheral blood, the patient will then need a bone marrow test or a lymph node biopsy. So that's a bit more awkward to do the TP53 testing. And in many cases, for that reason, in SLL patients, it's actually not being done. And so it is really important to kind of insist on having this test done with every course of treatment, before every course of treatment. I won't go, I will just say one thing about this. The take-home message essentially is that it is really important to be tested before each course of treatment, as the results of the TP53 test can go from negative to positive over time as you're having rounds of different types of treatment. And then also it's important that you ask your doctor to test for the mutation and not just for the deletion, because when you're just doing one test looking for a bit of a chromosome missing, which is done by FISH testing, then you only 4% of people will have this abnormality when they need treatment for the first time. That figure goes up to 12% if you're looking at mutation testing. And there's two different tests, and it's really important that your physician sends the test off for both, so that it's a complete test. Now that currently only happens actually in 29% of people in the UK. So there's a big problem with access to testing. It's not just accessing the drugs, but it's also accessing the test. And of course, as I just said, you have a different treatment. You get different treatment if your test result is positive. The other thing to say is that there are different, not just there's FISH testing to look for the bits of chromosomes missing. There's the mutation testing. There's different ways of doing mutation testing, and the more sensitive your test is, the more mutations it will pick up. Every test has to be clinically accredited and certified, so the laboratories that you are asking to perform those tests, they have to be diagnostic laboratories, but at the same time you also want to make sure that they're using a sensitive test, and the sensitive test that we are using in many places in the UK now is called next generation sequencing, and so that test will allow you to pick up even the smaller subclones, as we say, of TP53 mutations. So is ibrutinib then the frontline treatment for all? And I think I will just give you some summary plots. So just for those of you who are not used to looking at these plots, you see that the bottom line here is the time in months, and then on the y-axis we are measuring essentially the time it takes for the CLL to come back. Across a whole cohort of patients going into a clinical trial. In orange, the curve in orange shows the patient who got ibrutinib combined with an anti-CD20 antibody called obinutuzumab, and in blue is the people who got the chemotherapy with chlorambucil. And you can see very, very clearly here that patients who were treated with the ibrutinib combination lived a lot longer before the CLL came back. And a lot more patients also responded to the treatment in the first place. So this is clearly, these were patients with comorbidities, older patients, and it shows that the ibrutinib is a very good treatment for those patients. Even when you're then comparing this with a stronger chemotherapy in black, and this was a different study looking at ibrutinib in combination with rituximab or on its own, you can see that in black is the chemotherapy. It's again the same type of curve. You can see that the patients treated with ibrutinib did a lot better, and they lived for much longer without CLL than the patients treated with chemotherapy. You can also see that there's no difference between the patients treated with or without rituximab. So actually this intravenous antibody treatment that is expensive, and means that patients have to come up to date treatment units and be put on a drip, and they get side effects from that. Actually you can see that is not really necessary, and that the NHS in particular could probably save a lot of money by not giving the rituximab and just giving the ibrutinib. Last not least, then in August of this year, a study was finally published from the States that compared the very strongest chemotherapy that we only give to patients who are fit and they don't have any other comorbidities, they have good kidney function, etc. Compared this with ibrutinib and rituximab. And the difference here is on the y-axis is not just the time it takes for the CLL to come back, but it's actually the time people lived. And so what you can see from this study is that patients on ibrutinib, when they're being given ibrutinib as the very first treatment, that they live longer on average, and that they survive longer. And this, when you look at the number of events, i.e. the number of deaths, in the ibrutinib-treated patients, there were 4, but there were 354 cases treated because it was a 2-to-1 randomization. In the FCR, it was 10, so there would have been 20 roughly if they'd been treated, if that same number of patients had been treated. So this is a big difference between the chemotherapy and the ibrutinib. And you were going to ask me, now, what did those people die of when they were given FCR treatment? And it was basically a mixture of various different things: infections, the CLL not responding to treatment, some side effects, longer-term side effects from the chemotherapy. For example, also second cancers, because you know when you give chemotherapy, there's a risk that you develop cancer as well. So there's many different things. So this is an important study. But as I said to you before, in the UK, we still give FCR. This is our standard of care. We don't give anything else because we can't. So how is ibrutinib tolerated? Well, it's reasonably well tolerated. There are patients, however, with heart problems where I'm increasingly careful before I prescribe it. There's a risk of irregular heart rhythm, high blood pressure. And then some time ago now, our regulator here in the UK also said that there was a risk of more serious heart arrhythmias. There's a risk of bleeding, there's a risk of various different types of infections that we are very familiar with as hematologists, but it is not a drug without side effects. And so that's another sort of take-home message, is that just because it's not chemotherapy, just because it's a tablet, it doesn't mean that it doesn't have side effects. So ibrutinib does have quite a few side effects, and you are on this drug as a patient. You're on this drugs for years and years and years potentially, especially if you're taking it if you've never had any treatment. So the patients will take this for years and years and years. They might get leg cramps, they might get muscle aches and pains, which very often in these studies is not even mentioned because they're not serious side effects. But if you're on this drug for years and you have got leg cramps every evening, every night, 4 times a night, you get really fed up with it. So it's not really, we, as physicians, I think we have to be aware of that as well. So the other thing to say with ibrutinib is that it does not make the CLL go away completely. So when we measure tiny weeny residual elements of the remaining CLL, which is what we do these days as part of many clinical trials, we will find that we can detect CLL very easily still in the body. So when people are talking about MRD, it means measurable minimal residual disease. And it's a kind of measurement of the overall burden of CLL that you've got in your body. And you can do a CT scan or for blood count. That's all very well. If you want to do it in a really sensitive way, you're using this MRD measurements, and there are various different ways of doing that. I won't go into the details, but for us, this is a in some for chemotherapy agents, for example, or also for venetoclax, is a way of measuring the depth of the response. In ibrutinib, we can't use that measure because there is CLL around, even although patients are responding really well. So I've already alluded to this several times. The problem is continuous therapy for ibrutinib in frontline is unaffordable for many high-income countries, and that is effectively because there are too many people in frontline who require this treatment in frontline. So it's a very easy health economic argument. So AbbVie, then the company that produces venetoclax, came up with a very good solution to this, and they basically said, well, why don't we just give venetoclax over 12 months? And we're kind of combining it with an antibody, and then we're comparing this with chlorambusel and obinutuzumab. And this is the CLL14 study. A really important study, was published this year. Venetoclax is extremely well tolerated, doesn't have many of the side effects that ibrutinib has. The main thing is that it's so effective that actually when you're giving the high dose up front and you have a lot of CLL on board, then it can cause the tumor cells, the leukemia cells, to break down very quickly, and that can cause kidney failure, and you can die from that. So we are kind of dose escalating this really gradually, starting with a very small dose, and every week you're escalating. You have blood tests done. You are being given tablets and sometimes injections to counteract the effect of the tumorolysis. So it's the first 5 weeks for patients are usually a struggle. Sometimes you have to be admitted, to basically monitor quickly. Once you're over those 5 weeks, it's very well tolerated. And what did the study show? When you're comparing this to the chemotherapy in green, again, these are the same sort of progression-free survival curves. You can see that the patients treated with venetoclax and obinutuzumab lived much longer without CLL. This did not really translate into an overall survival benefit at this point. We actually think, when you're looking at all these different studies that I've presented so far, we think that the patients who benefit most in terms of the overall survival are the younger patients, because they don't have other comorbidities, and so they have got time, if you like, to go and get into trouble from CLL. So in those patients is of most benefit. And then importantly, when you're looking at venetoclax, the minimal residual disease measurements, it induces MRD in a large proportion of patients. So using very sensitive tools, it's about still kind of the 25-30% of patients who are MRD negative. If you're using not so sensitive tools, it's 75%. So it's a very potent drug. So to summarize the frontline treatment, in the UK at the moment, I would say, well, you have to go into a clinical trial. We have the FLAIR study open. The FLAIR study randomizes patients and put patients into 3 different arms, either chemotherapy or ibrutinib on its own or ibrutinib and venetoclax. And clearly, when I know ibrutinib is the best option, but I can't get access to it, I will put all my patients into FLAIR. Yes, there's a third of a risk that you get FCR treatment, but 2/3 of patients will get what we know already is the right treatment. So a clinical trial is, if available, is a good way of getting access to the state-of-the-art therapy if your governments can't afford it otherwise. Treatment initiation, really important message, that has not changed. It's symptoms and signs of progressive disease. So, just because you have got a few lymphocytes in your blood doesn't mean that you need treatment. If you have access to targeted therapy, then, ideally I would say that you should have an immunoglobulin mutation status. I didn't talk about this, and very much so the TP53 mutation status. And then you should be treated with the best available therapy. In the UK, is still chemoimmunotherapy, depending the intensity is depending on the comorbidities, on the age of the patient. Then hopefully soon, when NICE, if NICE approves it, we will have venetoclax and obinutuzumab in the UK. We don't know yet whether this will be only for frail patients, because that was CLL 14, or whether it would be for everybody, which would be the logical thing to do, but we don't know yet. If you have a TP53 abnormality, you're looking for sensitive mutation testing. It's ibrutinib that is NICE approved in the UK. And then possibly if you have a hypermutated immunoglobulin locus, then probably or possibly still with chemoimmunotherapy. So very quickly about relapsed refractory patients then. The first thing to say really is that chemoimmunotherapy after you've had treatment is definitely not the right treatment anymore. The second thing to say is that ibrutinib is definitely a very good drug, and that this has been demonstrated in many studies now. It's also NICE approved in the UK because the number of patients with relapsed CLL is much lower. So health economically for the government it makes sense to fund it in the relapsed setting but not in the frontline setting. And then the other options available in the UK is venetoclax on its own. And so at the moment, this is the study where venetoclax was given after ibrutinib, for example, or after relapsing from idelalisib. And you can see that the patients are, that they have an okay time, off about a couple of years off after relapsing after ibrutinib when they started on venetoclax. But it's not by no means a cure, and it's by no means a long-term solution for the majority of patients. So at the moment, what I do is that when I start a patient on monotherapy after ibrutinib relapse, I refer for transplantation if they are transplant eligible. And this again just shows the real-world data from the US, showing that if you are, if you are relapsing after ibrutinib, then venetoclax is a really good option. Alternative option that you switch from ibrutinib to idelalisib, or if you've had idelalisib at the beginning, you're then switching to ibrutinib, but that's not as good, doesn't seem to be as good as switching directly to venetoclax. So then there's another interesting study that was published and that is also now NICE approved in the UK, where we're giving a fixed duration, not monotherapy of venetoclax, but in combination with rituximab. I don't think the rituximab makes much of a difference. It's really the fixed duration that makes the difference. And so patients are being given venetoclax for 2 years. When you're comparing this with chemotherapy, that clearly the patient's living much longer on venetoclax. So in terms of the relapse therapy, there's really no role for chemoimmunotherapy at relapse, and that's probably bad news for most of you in the room, because in most countries, patients are still being treated with chemoimmunotherapy at relapse. Ibrutinib is a good option, but there are side effects. Venetoclax is definitely an option for the people who are relapsing after ibrutinib. And in a resource-limited setting, I will very provocatively say that I think that venetoclax plus minus DR is the best option because it's fixed duration treatment. And I would also say that in the frontline setting in particular, if it wasn't for the cost of venetoclax. So where are we? This is my last slide. Where are we now when we're summarizing all of this? It's kind of quite confusing, and it's a bit of a whistle tour. I'm very happy to discuss afterwards. But you can see that by no means is there equal access to therapies. There's no real, there's a consensus, I think a scientific consensus about what would be the right treatment. But because of various different trials, inclusion criteria, the ways regulators and payers are interpreting the data, the amount of money that is available, we see at the moment at least that there's a huge variability and variation in therapy across the world. And there's the equal variability to accessing precision diagnostics across the world. And of course, it's all very well to use these buzzwords of precision medicine and targeted therapies, etc., etc. One problem is the access to therapy, but if we don't get the diagnosis right at the beginning, then that is a huge problem at the beginning. And so I think precision medicine is always about those two things. We need to get the diagnostics right before we can start jumping onto precision therapeutics. And I would like to finish with a little advertisement for any kind of upcoming future leaders in precision medicine. The University of Oxford is now offering an online part-time MSc over 2 years. So anybody across the world, it's a global program, anybody across the world can join. It's only 2 weeks of nice Oxford student life, including an exam. Involved with this. The rest of the time you can be at home at your computer and learn all about precision medicine. Thank you.